Right. Hitting the ground running today. Straight into some hardcore ortho for you future surgeons out there.
Yeah.
You know those massive exams you're all prepping for, like the FRCS?
Oh, yeah.
We're diving deep today into osteoarthritis. Basic science, the stuff you gotta know to absolutely nail those exams. And we've got a secret weapon to help us decode all the must-knows. We're using the Ortho Made Simple notes from mokyingren.sg.
Excellent resource.
Yeah. Put together by a rock star surgeon, Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore.
Impressive.
Yeah. And here's the kicker. He just aced his FRCS back in 2022, so we're talking fresh insights, hot off the press kind of stuff.
Fantastic. Glad to be diving into this with you. Such a common condition, and really getting that core understanding is key, beyond just memorizing facts for the exams.
Totally. It's like, okay, picture this. You're in clinic. Your next patient walks in. They've got stiff and painful joints, right? Pretty classic presentation, but how do you know if it's just, part of getting older or if it's the big O, osteoarthritis?
Yeah, the classic dilemma.
Exactly. That's what we're tackling today in this deep dive, going beyond just the surface level to really grasp what makes OA tick and, how it all works at that deeper level. And since these notes are specifically designed to help you crush those exams, we'll make sure to laser focus on all the high-yield info.
Sounds good. Let's kick things off by making sure we're all on the same page about what OA actually is, It's often oversimplified as just wear and tear, but it's way more dynamic than that.
Right. There's got to be more to the story.
Absolutely. Think of it more as this ongoing loss of that smooth, articular cartilage, that nice gliding surface in our joints. And it's not just the cartilage. There's also remodeling going on in the bone underneath it, the subchondral bone.
So there are multiple players involved.
Definitely. And that word you used earlier, progressive.
Right.
That's key. This isn't a one-time thing. OA is a continuous process.
Okay, so what's the first domino to fall? What actually sets this whole cascade in motion?
Often it starts with what we call fatigue wear of the cartilage. Think of it like, the shock absorber in your car.
Okay, I can visualize that.
Over time, with all that stress of repeated loading and unloading, tiny little cracks and damage start appearing in the cartilage.
Right, like micro damage building up over time.
Exactly. And that cartilage, it's not just a simple uniform layer. It has this beautifully intricate structure with collagen fibers providing strength and proteoglycans helping it resist compression.
Yeah, they work together to give it that, springiness and ability to absorb shock.
Precisely. And when that structure starts to break down, the cartilage becomes more porous, which actually makes it less stiff initially because more water can seep in.
Wait, hold on, less stiff. So at first, it seems like it's getting better, not worse. But we know OA is all about stiff joints. How does that happen?
It's a bit counterintuitive, right? It's like when a dry sponge becomes more flexible after it soaks up water. The problem is that extra water, along with the weakened collagen, actually make the cartilage even more vulnerable to damage.
Ah, I see. So it's like a temporary illusion of improvement.
Exactly. Now, here's where things get even more interesting. Those damaged chondrocytes, the cells that normally maintain the cartilage, they start releasing these enzymes called matrix metalloproteinases. MMPs for short.
MMPs, they sound kind of scary, like tiny little Pac-Man chomping away at the cartilage.
That's actually a great analogy. Think of MMPs as demolition crews. They break down the cartilage matrix even further, weakening the structure and fueling this vicious cycle of damage.
Oh, man. So the cartilage is basically under attack from the inside out. But surely the body doesn't just sit back and watch this happen.
Of course not. The body tries to fight back. It increases the number of chondrocytes, trying to outpace the destruction and repair the damage.
Okay, so it's like a battle going on in there.
Exactly. Sadly, with OA, this valiant effort just can't keep up. It's a losing battle in the long run.
So we've got this whole microscopic war zone happening inside the joint. I'm curious, how do we actually classify OA? Is it all just lumped together as one condition?
Good question. As clinicians, we need to be able to tell different types of OA apart. We broadly divide it into two main types, primary and secondary. Primary OA is sometimes called idiopathic OA, meaning we don't really know what causes it.
Like it just appears out of nowhere.
Yeah, it's the one that makes us scratch our heads and say, why this patient, why this joint?
I know that feeling.
Oh.
Then there's secondary OA. What makes it different?
Secondary OA develops because of something specific that we can identify, like a previous injury, a condition like gout, or even something called a vascular necrosis, where the blood supply to the bone gets disrupted.
So it's like OA with a clear backstory.
Exactly. And that backstory is super important because it changes our whole approach to managing the condition. Especially in younger patients or those with a relevant history, we really need to dig deep and look for those secondary causes.
Nice detective work, right? You got to find the root of the problem.
Exactly. Now, let's zoom in and take a closer look at what's happening visually inside those affected joints macroscopically, meaning what we can see with the naked eye. We see changes like softening of the cartilage, fraying, pitting, erosion. It's like looking at a road surface that's gone from smooth asphalt to all cracked and pothole-ridden.
Okay, so we can actually see the damage. It's not just theoretical.
Right, it's very real. But what about at the microscopic level, the stuff that we need to know for those tricky exam questions? What are the key things to remember about the microscopic changes in OA?
Excellent point. Microscopically, we focus on three main components: the matrix, the cells, and the enzymes. Remember how we talked about the cartilage matrix being made up of collagen, proteoglycans, and water?
Yeah, the scaffolding that holds it all together.
Exactly. In OA, we see a decrease in those proteoglycans, so the cartilage loses some of its ability to resist compression. The collagen network, which provides tensile strength, also weakens. And as we discussed, there's more water hanging out in the cartilage because of those little micro tears and damage. So it's basically losing strength and structure on all fronts.
Pretty much. And what about those busy little chondrocytes? Are they still trying to hold things together?
They're working tirelessly, but it's often too little too late. And those pesky MMPs are still running around wreaking havoc. Their destructive activity is actually made worse by inflammatory molecules called cytokines, like IL-1, which are abundant in OA joints. It's a recipe for ongoing damage. It's like a never-ending demolition derby in there.
Okay, this is all making sense, but I gotta ask the question that I'm sure is on everyone's mind.
Yeah.
How is OA different from just getting old? I mean, both involve our joints changing over time, right? What's the real distinction?
The million-dollar question. It's a super important one, and it can be a bit counterintuitive. While both aging and OA involve joint changes, there are some key differences that are crucial to understanding.
Okay, lay it on us. What are the key differences we need to know?
So in OA, remember how the collagen and proteoglycan content actually decreases?
Right, it makes the cartilage softer and weaker.
Right.
Exactly. Well, in normal aging, those components are generally maintained, so the joints actually get stiffer as we age.
Whoa, hold up. So aging makes joints stiffer, but OA makes them softer, even though they both involve wear and tear. That just seems backwards.
It's definitely counterintuitive. But think about it this way. In OA, that decrease in collagen and proteoglycans, along with the increased water content, makes the cartilage less able to resist forces, so it becomes softer. But in aging, those components stay relatively intact, so the cartilage retains more of its stiffness.
Okay, that makes sense. I guess it's the type of change that matters, not just the fact that there is
Yeah,
change.
exactly. What about those chondrocytes? Any differences there between OA and aging?
You bet. In OA, there's an increase in chondrocytes as the body desperately tries to repair the damage. But in aging, we actually see a decrease in the number of chondrocytes. Interesting. So even at the cellular level, aging and OA are going in opposite directions.
Exactly. It highlights the fact that these are two distinct processes, even though they can sometimes look similar on the surface. Knowing the differences is key to managing them effectively. Now, I know we're focused on exam prep, and these Ortho Made Simple notes from mokyingren.sg are a fantastic resource. Speaking of aging, there's another factor that plays a role in both aging and OA.
AGs.
Ah, yes. AG's advanced glycation end products. This always sounded so complex to me.
They might sound intimidating, but they're basically just molecules that form from interactions between sugars and proteins. They naturally accumulate as we age, but they also contribute to the development of OA.
Hold on, so AGs are involved in both aging and OA. How does that work?
Think back to that fatigue where we talked about earlier. AGs actually make cartilage more susceptible to that kind of damage. They make the tissue stiffer, but also more brittle, kind of like how metal can become brittle after repeated stress.
So AGs are like little saboteurs, weakening the cartilage and making it more prone to breaking down. That's a great way to put it. And this really highlights how understanding the basic science can help us connect the dots clinically.
Totally. So it's not just about memorizing facts. It's about seeing the bigger picture and how everything fits together.
Exactly. And to really hammer home the distinction between OA and just getting older, it's important to remember that OA has a significant inflammatory component. Those cytokines like IL-1 and those destructive MMPs are key drivers of the whole process.
Right. They're the ones fanning the flames of destruction, so to speak. And that inflammation is something we don't typically see in normal aging.
Exactly. So while both aging and OA can lead to joint changes, the underlying mechanisms and the key players are different.
Okay, this is all starting to click into place. Now, before we move on, there's another condition we need to be able to differentiate. Rheumatoid arthritis. Is that just a super severe form of OA?
That's a common misconception, but rheumatoid arthritis, or RA, is a totally different ballgame. It's an autoimmune disease, which means the body's immune system is basically attacking its own joints.
So it's like friendly fire gone wrong.
Exactly. And this immune system attack triggers a cascade of inflammation, leading to the release of those cartilage-destroying enzymes we talked about earlier.
Right, the MMP.
Exactly.
Right.
We also see synovitis, which is inflammation of the joint lining, and the formation of panellus, which is this abnormal tissue that can erode the joint.
So even though they start off differently, RA and OA can both lead to joint damage and pain.
You got it. Understanding the different pathways is essential for choosing the right treatment approach. Now, should we shift gears and talk about the different types of cartilage found in our bodies? This is where understanding the nuances can really set you apart in your exams.
Sounds good. And for our listeners, remember all this awesome info and much more is available in the OrthoMade Simple Notes over at mokyingren.sg. There is seriously a game changer for anyone prepping for those big orthopedic exams. Okay, so we're back and ready to tackle those different types of cartilage. It's not just one uniform substance, right? It's easy to just lump it all together.
Yeah, it's tempting to oversimplify it, but like anything in the body, there's nuance. Different types of cartilage, each with their own unique job to do.
Makes sense. So what types should we be focusing on for those exams?
Let's stick to the big three for OA, hyaline cartilage, fibrocartilage, and elastic cartilage.
Okay, starting with hyaline. What's the deal with that one?
Hyaline cartilage is the one we've been chatting about so far, actually. It's the most common type, and it's what covers the articular surfaces of most joints, knees, hips, shoulders, all about that smooth, glassy surface that lets our joints move effortlessly.
Right, so that's the classic joint surface cartilage, the one that really takes a beating in OA.
Yeah, right.
What about fibrocartilage? Where does that fit in?
Fibrocartilage is the tough guy of the cartilage world. It's more fibrous, built to withstand higher forces and resist those pulling tensile stresses.
So it's like the heavy-duty shock absorber.
Exactly. Think about the menisci in the knee, the discs between the vertebrae in your spine, the labrum of the hip. They're all made of fibrocartilage.
Makes sense. It's in those areas that need that extra strength and durability.
Okay. And last but not least, elastic cartilage.
Elastic cartilage is all about flexibility and, well, elasticity. Those structures that need to bend and snap back without breaking, like your ears and your epiglottis.
So we've got smooth mover, heavy lifter, and flexible friend. I like it. But how does knowing about these different types of cartilage actually help us understand OA better?
Great question. While OA primarily targets hyaline cartilage, that smooth articular surface, fibrocartilage can also be affected, especially in conditions like meniscal tears or degenerative disc disease.
So understanding the different types helps us predict which joints might be more vulnerable to OA and how the disease might present differently depending on the location.
Exactly. It's all about connecting the basic science to the clinical picture. Now let's zoom in even further and talk about the actual structure of cartilage. What makes it so strong and able to handle all that wear and tear?
Yeah, how does it withstand all that force without just crumbling? It all comes down to its unique composition. Cartilage is made up of specialized cells called chondrocytes that live within a complex extracellular matrix.
Okay, the extracellular matrix sounds a bit technical. What is that exactly?
Think of it as the scaffolding that supports the cells. It's a mix of collagen fibers, proteoglycans, and water. The collagen provides tensile strength, the proteoglycans resist compression, and the water keeps everything hydrated and lubricated.
It's like a perfectly engineered system, each component playing a crucial role.
Precisely. And when they work together seamlessly, they give cartilage its amazing strength, flexibility, and shock-absorbing abilities.
But as we've learned, even the toughest cartilage can break down over time. What are the main culprits that contribute to this breakdown?
Well, there are a few key players: mechanical stress, inflammation, and enzymatic activity.
Okay, let's break those down, starting with mechanical stress.
Every time we move, our joints are loaded and unloaded, right?
Makes sense.
Under normal circumstances, cartilage can handle that stress and repair itself. But when the stress is excessive or repetitive, it can overwhelm the system, leading to those micro tears and damage we talked about earlier.
Right, like pushing that shock absorber to its limits until it eventually wears out. What about inflammation? How does that play into cartilage breakdown?
Inflammation is a tricky one. It's essential for healing, but chronic inflammation can actually speed up cartilage damage. When a joint is inflamed, cells release inflammatory signals called cytokines.
Yes, those cytokines. the little troublemakers that amplify the damage.
Exactly. And one of the key cytokines involved in OA is IL-1. These cytokines stimulate the production of those cartilage-degrading enzymes, the MMPs. It's like sending in a demolition crew to dismantle the scaffolding.
So we've got mechanical stress overloading the system and inflammation sending in the demolition crew. It's a recipe for disaster.
That's a great way to put it. And it really highlights why managing both mechanical stress and inflammation is crucial for treating OA. Now, let's zoom out a bit and talk about the epidemiology of OA, who gets it, and how common is it?
Yeah, let's get a sense of the big picture.
Well, unfortunately, OA is the most common joint disorder worldwide, and it's on the rise. It can affect people of all ages, but it becomes much more common as we get older.
So those aches and pains we start to feel as we age, OA is often the culprit.
Definitely a major player. And while OA can affect any joint, it tends to target weight-bearing joints like the knees, hips, and spine. They bear the brunt of the load day in and day out.
Makes sense. So age is a big risk factor, but are there other things that increase our chances of developing OA?
Absolutely. Gender is a factor. Women are more susceptible than men, especially after menopause. This is partly due to the decline in estrogen, which actually has protective effects on cartilage.
Interesting. So hormones can play a role. What else?
Genetics also play a part. If OA runs in your family, you're at increased risk. And as we mentioned earlier, obesity is a huge risk factor. Excess weight puts extra strain on those weight-bearing joints, accelerating cartilage wear and tear.
It's like adding fuel to the fire.
Exactly. And we can't forget about previous joint injuries. Trauma to a joint, like a ligament tear or a fracture, can disrupt the biomechanics and increase the risk of OA down the road.
So even those old sports injuries from our younger years can come back to haunt us.
Unfortunately, yes. It all adds up. OA is truly a multifactorial condition influenced by a complex interplay of factors.
It's like a puzzle with multiple pieces contributing to the overall picture. Understanding those pieces is key for developing effective prevention and treatment strategies. Speaking of treatment, let's dive into the different approaches for managing OA. All right, let's talk treatment. What can we do to help our patients with OA? Remember, listeners, we're laser focused on those key takeaways, the stuff you absolutely need to know to rock your exams. And the Ortho Made Simple notes from mokyingren.sg are your secret weapon for that.
Totally. There's no cure for OA, but the good news is we have tons of options to manage symptoms, slow down progression, and improve quality of life.
So it's all about empowering patients to live well, even with OA.
Exactly. And treatment usually involves a combo of non-pharmacological, pharmacological, and surgical approaches, hitting it from all angles.
Okay, let's break those down. What are some of the first-line non-pharmacological interventions?
Non-pharmacological approaches are the foundation of OA management. We're talking lifestyle modifications like weight loss, exercise, and physical therapy.
The classic trio. How do they specifically benefit patients with OA?
Well, weight loss is huge.
Yeah.
Taking that extra pressure off the weight-bearing joints can really help slow down cartilage degeneration. Then there's exercise, particularly strengthening those muscles around the joints, which provides better support and stability.
It's like giving those joints a helping hand.
Exactly. And physical therapy is fantastic for improving range of motion, flexibility, and overall function.
So it's a holistic approach, targeting multiple aspects of OA.
Absolutely. And often these interventions work best together. A physical therapist can tailor an exercise program to a patient's specific needs and limitations.
That makes sense. So we've covered weight management, strengthening, and functional improvement. What about pharmacological options? What kind of medications are we talking about here?
Pharmacological interventions aim to control pain and inflammation. Over-the-counter analgesics, like acetaminophen, are often the first line of defense. If those aren't enough, we can consider NSAIDs, the nonsteroidal anti-inflammatory drugs. They're more potent for pain relief and also tackle inflammation head-on.
But NSAIDs come with those potential side effects, right? Especially with long-term use.
That's right. We have to be cautious with NSAIDs, especially in patients who might be at risk for gastrointestinal or cardiovascular complications. In some cases, topical NSAIDs applied directly to the affected joint can provide more localized relief with fewer systemic side effects.
So the choice of medication really depends on the individual patient, the severity of their symptoms, and their overall health. Makes sense. Are there other pharmacological options we should have on our radar?
Yep. For those patients with persistent pain and inflammation despite other treatments, we can consider injections directly into the joint tape. Corticosteroids provide temporary relief by reducing inflammation, and hyaluronic acid injections aim to restore the viscosity and lubrication of the synovial fluid.
Ah, so those injections deliver the medication right where it's needed. And while these non-pharmacological and pharmacological interventions can be super effective, at what point do we start thinking about surgery?
Surgery is typically a last resort. When conservative measures have failed or when the joint damage is too severe. The type of surgery depends on the joint and the extent of the damage.
Okay, so what are some of the surgical options?
Arthroscopy, which is minimally invasive, can be helpful for cleaning out the joint, removing loose debris, or even repairing damaged cartilage. Osteotomy is another option. It involves reshaping the bone to better align the joint and redistribute weight-bearing forces.
So arthroscopy is like cleaning up the damage, and osteotomy is more about realigning the structure.
Exactly. And for end-stage OA, when the joint is really severely damaged, joint replacement surgery might be necessary. These procedures replace those damaged joint surfaces with artificial components, restoring mobility and relieving pain.
Joint replacements can truly be life-changing for patients who've been struggling with severe OA. It sounds like we have a whole toolbox of treatment options, each playing a specific role in managing this complex condition. What about the future of OA treatment? Any exciting new developments we should be keeping an eye on?
Definitely. The field is constantly evolving, and there's tons of exciting research happening. One area of focus is developing disease-modifying osteoarthritis drugs, or DMOAs.
DMOAs, what makes them different?
These aren't just about managing symptoms. They actually aim to slow down or even halt the progression of the disease.
Wow, that would be a game changer. Anything else on the horizon?
Regenerative medicine is another hot topic. Scientists are exploring ways to use stem cells, growth factors, and other biological therapies to regenerate damaged cartilage.
So the dream of regrowing cartilage might actually become a reality.
The potential is definitely there,
Okay.
and as our understanding of OA continues to grow, so will our ability to develop even more effective and targeted treatments. This has been an incredible journey through the world of OA, covering everything from the basic science to the latest treatment advances. And remember, listeners, all this fantastic info and more is available in those amazing Ortho Made Simple notes by Dr. Mok Ying Ren, available at mokyingren.sg. They're a must-have for any orthopedic resident.
Couldn't agree more. They're a lifesaver for anyone prepping for those orthopedic exams. And we're back for the final stretch of our OA deep dive. And we can't talk about OA without talking about imaging. Right. It's crucial for everything from diagnosis to treatment planning.
Absolutely. It's like trying to navigate in the dark without a map. Imaging gives us that clear view of what's happening inside the joint.
Exactly. So let's start with the OG of imaging, the good old X-ray. What are the key things we should be looking for when we're evaluating an X-ray for OA?
Oh, the first thing that jumps out, like the big flashing neon sign, is joint space narrowing.
Okay, joint space narrowing. Why is that such a telltale sign of OA?
Remember, OA is all about that cartilage loss. And as the cartilage thins out, the space between the bones gets smaller and smaller. It's one of the most reliable indicators of OA on an X-ray.
Got it. So joint space narrowing, that's our red flag. What else should we be on the lookout for?
Another classic finding is something called osteophytes, also known as bone spurs. These are bony outgrowths that form around the edges of the joint, often in response to those altered biomechanics and increased stress that we see in OA.
So it's like the body's trying to stabilize the joint, but it ends up creating these bony protrusions. Not the most elegant solution. Can those osteophytes cause pain?
They can, especially if they start impinging on surrounding structures, like nerves or tendons. It's one of the ways OA can cause pain and limit movement.
Makes sense. What else do we see on those OA X-rays?
We also often see subchondral sclerosis, which is increased bone density beneath the cartilage. This happens as the bone tries to remodel and cope with that increased stress and strain that it's under.
So the bone is basically getting denser and harder to compensate for that weakened cartilage. It's amazing how adaptable the body is.
It is. And lastly, we might see subchondral cysts, which are fluid-filled sacs that form within the bone.
Cysts in the bone. That sounds a bit unnerving.
They can be painful and contribute to the overall discomfort of OA. These cysts are thought to arise from tiny little fractures in the bone and the intrusion of synovial fluid.
So it really is a whole jointed disease, not just cartilage.
Exactly. OA affects the entire joint structure in various ways.
Okay, these radiographic findings seem pretty straightforward, but I'm guessing there are nuances that can make it tricky to distinguish OA from other conditions, right?
You're absolutely right. It's not always black and white. There can be overlap in the radiographic features of different joint conditions. So it's crucial to consider the patient's history, their symptoms, and our findings from the physical exam alongside those imaging results.
It's like putting the pieces of a puzzle together. So X-rays are a must-have. But what other imaging modalities can give us a more complete picture of what's happening in an OA joint?
Well, while X-rays are great for visualizing the bony changes, other modalities can give us a clearer view of the soft tissues, like the cartilage itself, the ligaments, the tendons, and the synovial membrane.
So we can get a more detailed look at all the structures involved. What are some of those other imaging tools we have in our arsenal?
MRI magnetic resonance imaging is a powerful tool for visualizing those soft tissues. It can pick up early cartilage changes that might not show up on an X-ray, and it lets us really assess the severity of the cartilage damage and inflammation.
So MRI gives us a much higher resolution view of the joint.
Exactly. And then there's ultrasound, which is particularly useful for evaluating those soft tissues, especially tendons and ligaments.
Ultrasound. So what's the advantage of using ultrasound for OA?
Well, for one, it's a dynamic imaging modality. We can actually see how those structures move and interact in real time, which can be super helpful. Plus, we can use ultrasound to guide injections into the joint, ensuring we deliver the medication precisely where it needs to go.
So it adds that real-time element to our imaging toolbox. It's like we're watching the joint in action.
Exactly. And each modality has its own strengths and limitations. Choosing the right one depends on the specific clinical question, the patient's needs, and the resources we have available.
Well, there you have it, folks. A whirlwind tour of OA basic science. From those microscopic changes to the imaging essentials, all thanks to the Ortho Made Simple notes by the incredible Dr. Mok Ying Ren. If you're gearing up for your FRCS or any other orthopedic exam, head over to mokyingren.sg and check out those notes. They are a game changer.
Couldn't agree more.
Remember, the key to mastering OA is to visualize what's happening at every level, from the microscopic to the macroscopic. Keep those images in your mind, and you'll be well on your way to confidently diagnosing and managing this common condition. Thanks for joining us on The Deep Dive. See you next time.